After a long wait of about 5 years, the Surviving Sepsis Campaign Guideline panel of experts have dropped their new guidelines for Surviving Sepsis Campaign that will be followed for the next 5 years. And actually, in 10 years, there has been an ocean of changes. The paradigmal shift that every intensivist who confronts sepsis and septic shock in the ICUs should know, should understand, and implement in the days to come. In this video, I am going to present before you the 10 most important updates from the executive summary. It's time we write obituary of the Q-SOFA score. It has a very poor sensitivity and often misses very potential cases of sepsis and septic shock. So it is time to adopt to newer scoring systems like Muse, Muse 2 or Muse, which are more accurate, sensitive, and picks up cases pretty early and accurately. Giving IV antibiotics within the first 60 minutes still remains in focus. Patients with definite sepsis, probable sepsis, but without shock will still remain in the same privilege window. Only in case of diagnostic dilemma and no hypotension, this window has been extended to 3 hours in order to reduce unnecessary use of antibiotics. The new recommendation is brand and bold. For the first time, it has been recommended that on-field IV antibiotic be administered. If a patient is in transit and the hospital is 60 minutes away or at a distance of more than 60 minutes, IV antibiotics should be given to a patient with probable sepsis and definite shock. This will reduce the lag time between giving IV antibiotics and increase chances of survival. Besides acknowledging the importance of beta-lactam antibiotics, the guidelines now officially acknowledge extended infusions or continuous infusions of these antibiotics. These are all time dependent antibiotics, and giving them as an extended or continuous infusion gives us a chance to keep the levels of the antibiotics in plasma well above the MIC levels, which increases their efficacies by many fold. While 30 ml per kg of IV fluids still remain the mainstay of therapy during resuscitation, the emphasis is now on calculating the ideal body weight for calculation of the total fluid volumes. We remain with the choice of crystalloids as IV fluids, that is Ringer's lactate or other balanced crystalloids, unless it is a traumatic brain injury where the sodium chloride, the normal saline, becomes the automatic choice. Relaying the lower the better concept, we now have a lower MAP target, especially for people of the higher age group. For those over 65 years of age, we now have a MAP target revised to 60 to 65, in contrary to the stellar figure of 65 that we have been staggering over for years. This is definitely going to reduce the use of vasopressors, and overexposure to vasopressors might result in ischemic events as well as arrhythmias, which is definitely going to be reduced. Maybe we'll use a little less volume of IV fluids as well. The concept of de-escalation of antibiotics has been in discussion for long and has now been emphasized by the newer guidelines for surviving sepsis. It is said that once the microbiological profiling is complete and we have the culture sensitivity results, no one should be lethargic about de-escalating to a lower antibiotic. This would not only reduce the use of broad-spectrum antibiotics, reduce the chances of development of antimicrobial resistance, but also contribute positively to the global antimicrobial stewardship program. Too much of fluid is never good. The ROSE concept of IV fluid has now received the desired emphasis from this update or guideline. After we have completed resuscitation, optimization, and stabilization has been achieved, we should focus towards evacuation. Use diuretics to shed off the extra fluid in the body of the patient. This would not only improve cardiac function, but also help us get rid of a lot of complications due to volume overload. For the first time ever, suggestions for gut decontamination has been given by the update guidelines. They say that gut decontamination can actually help in patients who are on ventilator and in such settings where multi-drug resistant bugs are low in incidence. The post-discharge roadmap has for the first time been given due importance in the management of sepsis, which says that the management of sepsis or septic shock does not end with a discharge. We should follow up and follow through with the patient in the journey following discharge, where mental and physical rehabilitation, cognitive follow-up, psychosocial support, everything helps the patient to get the essence of life and ensure sense of well-being. Finally, the bonus. Time to glance through which all are out of practice. Large doses of antibiotic uselessly given to patients, vitamin D, intravenous vitamin C, use of probiotics are all actually out of practice, and immunomodulators are yet to receive their due importance.